We're listening at home. We are recording. We just started. Problem. So right now, and so let's say a daughter or a son might say, you know, my dad is a fighter. So respect statements would be, yeah, he is. He's such a strong person. He's been through so much. I admire that so much about him. And I really admire how much you care about your dad. It must be incredibly challenging to see him so sick. You know, I can't imagine what you must be going through. Tell me more about what your dad, what matters most to him. So that's a nice transition statement. So when you name the emotion, it really helps patients feel heard and it identifies and validates their feelings. And this is a kind of a plug for this great book, Humble Inquiry, The Gentle Art of Asking Instead of Telling. When we do this as a question, or we just, you know, even when we flat out name it, people really tend to appreciate that. So you might normalize the emotion and say, you know, some people might feel angry in your situation. This is a great way to respond if somebody becomes silent and you're trying to kind of pull out some reaction from the patient or the caregiver. Or I'm wondering if you're feeling sad, which shows you're listening and you're curious. Understands like this must be so hard. Or I would definitely avoid saying, we just understand, we do things that I can't imagine what you must be feeling. Are also very powerful because they really like what they're doing is right, and it really validates their support, you know, of a caregiver, for example, or a son or daughter. So your father is so fortunate to have your support. I can see you're a true champion for him. People want to hear that. They want to know that they're doing the right thing. Support statements. I really like using our and we. People are behind them and supporting them. We'll be here to help you. Things like that. And then, so this is, we often, the emotion, and we might hear things like, patient. You could say something like this: can you share with me what a miracle might look like to you? Really have the patient's family, you know, talk through that with you. And then, you know, I wish for a miracle too, but I worry, I worry that your mother is not things like when a patient says they don't want to be a vegetable. Oh, you know, try CPR on me, but you know, when I become a vegetable, I don't want it anymore. So what does that mean? You know, just asking them. You know, you mentioned that. What does being a vegetable mean to you? And then tell me more. Oh, thanks, Danny. Can you hear me now? Okay.
Is it? Are you guys still able to understand?
Okay. All right. Relief. Okay, yeah, we'll go up. We'll go upstairs. Just give us a minute we're gonna change spots to get better Wi-Fi.
Might just be back here.
Okay.
Grab it later.
Yeah. Okay. Okay, we're on a different floor, so hopefully this Wi-Fi is gonna be better for us.
Yes, I'm all done.
Okay.
You need to sit here.
Oh. All right, so great. Awesome. Thank you, Dr. Cobley. You heard us going up the stairs. Okay. So let's talk about some I wish statements. So I wish statements are, like I said, are very powerful, and they empathically confirm serious news. So this is a great way to, let's say you are struck with a question or a difficult statement from a family member, and you're like, man, this is bad. I don't know what to say. When you say things like, I wish I had better news, or, I wish we were in a different place too, it just really kind of deflates that tension, and it also really creates that partnership with the patient's family when you start using I wish statements. And we like to combine it with I worry. I actually accidentally, in the previous slide, said a but statement, and you actually want to avoid that. So when you combine I wish and I worry statements together, I'd like to do that. I tend to try to do that when we use it in two different sentences or with an and. I know this sounds like some little semantics here, but it actually can make a big difference, because when you say but, it can actually kind of essentially diminish the I wish statement. So something like, I wish for a miracle too, and I worry the interventions aren't working. Or I wish for a miracle too, and it seems that your father's treatments are not working, and his body is telling us that that he's dying. These are the phrases that I think becoming more comfortable with are really important. So when we start the conversation, and then when we transition throughout the conversation, asking for permission is huge. So one, it allows patients and their surrogate staff control, and two, it kind of gives us an opportunity to transition between topics naturally. So when you start the conversations, you might say something like, would it be okay if we talked about how you're doing with your health? Or after you've delivered serious news and you've attended to emotion, you could say, I would like to get a better understanding of what your father would have wanted at the end of his life. Can we discuss this? And now that you have, heard values, let's say, for example, from this instance, and you summarized it, you might say something like, now that I have a better understanding about what's important to you, would it be okay if I make a recommendation? We, should feel empowered to make recommendations regarding LSTs now that we know patients' values and goals. So when we are going through goals of care conversation and we're aligning and reflecting, it really allows, when we repeat what we've heard the patient say or what the surrogate says, it really allows for them to feel understood and heard, and it really just obviously crystallizes our understanding. So you could say something like, it sounds really like it's really important to you to spend time with your family and be at home. You'd like to be as independent as possible. And just literally restating verbatim what somebody says is really powerful too. Seems like you're worried that stopping this medication might make your pain worse. Tone of voice and therapeutic silence are also very important, especially with telehealth. It might feel a little unnatural, but things like, statements like, take your time, I'm still here, and then being quiet, it may feel like a little bit longer of a period of time for you, but for our patients or our surrogates, it's not, it's actually really beneficial. So now we're going to start our goals of care conversation. I think we've all probably said something like this. So we're finished with our H&P, and we really need to hurry up. We just need to get their code status. We have to do it. So we'll just say something. Would you like us to try to restart your heart if it stopped? Or what about, would you like us to do everything possible if your father's heart stops beating and stops breathing? What are some unintended consequences of these questions? Yes, right, of course. I mean, who doesn't want the buffet? Who doesn't want everything? And, oh, thank you, not here. Yeah, exactly. So one is also like, our hearts are not light switches, right? I mean, yes, in theory, that's what we're trying to achieve with CPR. We want to get ROSC, but it's when we phrase it like that, it seems like CPR outcomes are just so great. I mean, just like on TV, right? And they're not. And like I said, doing everything it really frames it like, well, if I don't do everything, I'm not doing right by my loved one. Of course, I want everything for them. So we need to kind of reframe it. And then of course, like if somebody is dying, and we're thinking that the patient would probably not do well with further interventions, instead of saying, I think it's time to withdraw care, we might say something like, I think that, I'd like to talk about compassionate extubation. Would now be an okay time for us to, address some of my concerns regarding his health, his course up to this time, things like that. So when you introduce the conversation, we're going to orient the patient and the surrogate, and we want to create a safe space. So you might say something like, it's important to make sure we provide care that aligns with what matters most to you. To do that, it's helpful to understand that what you hope for with your healthcare. Today, we'll talk about how we can best support your goals and preferences. And we want to ensure that patients know who their surrogate decision maker is if they lose decision-making capacity. This is really important. And if they don't know what that is, we educate them. And if they don't have that, we definitely should be asking our social workers for help to complete an advance directives. So you could ask something like, is there someone you trust to make decisions for you if you were not able to do so for yourself? And you could also say something like this. It's a little longer, but it's helpful for the medical team to know if you'd want to communicate your wishes if you weren't able to make healthcare decisions for yourself. Have you thought about who that might be? Oh, Natalie, yes, I see. Side of fries. Yeah, right, exactly. And it like refills. All right. So let's say we're talking to the surrogate, and this is from Respecting Choices, which I really like. So the VA uses Vital Talk and it's adapted Vital Talk, but Respecting Choices is a really nice roadmap as well. I'll send that out. So this is one way you can start the conversation with a surrogate. It's important we understand what matters most to your spouse or partner in the event he becomes seriously ill. We're eager to make sure we understand what he would want. As the healthcare agent for him, your role is to help us follow his previous decisions and make decisions in difficult moments that align with his goals, values, and preferences. It can be a lot to take in at once, and we'll support you through this. This is an opportunity for your partner's goals and values to be honored. Some think of these conversations as a gift of love to ensure your loved one's wishes are respected. So you'd be surprised how receptive people can be to things like that. And then, in the time of COVID specifically, you might say something like, it's hard to know if a sudden illness like COVID-19 could leave your partner seriously ill. By giving direction ahead of time, we'll know what matters most to him and can recommend treatments that match his goals and values. And whatever the choice, he'll be treated with respect, dignity, and comfort. So I won't go through the surrogate hierarchy for surrogates, but just so you're aware, I think this is legally also in the state of Ohio, obviously. So you'll have it there when you get the PowerPoint. When you're trying to get a better understanding of the patient's understanding or the surrogate's understanding of the patient's health and prognosis, you might just ask questions like, tell me what you know about your health, or what do you understand about the complications of COVID-19 in the context of your partner's medical conditions? This helps you get a better understanding if they, like Danny had asked earlier, if they even know what DNR means, for example. And, reframe if necessary. So if there is a disconnect or like an incongruency with maybe somebody's illness trajectory and what their values and goals are, or what their stated LSTs are, I think then this is an opportunity where we can provide information. We can always ask for permission first and then reframe. I worry your advanced COPD really limits your function. Would that be okay for us to talk about? Because knowledge gaps can lead to mismatched treatments. So there was a great study in JAGS this year, the Journal of the American Geriatric Society, which talked about, was a sub-analysis of the, looking at the resuscitation appropriateness, and it looked at 80-year-olds in out-of-hospital cardiac arrest. And what it found is that providers, especially in the ER, have, higher level of idea of appropriateness for CPR compared to how poor the outcomes actually are. So why is this? I mean, there's a lot of reasons why this is, and the sub-analysis, which I'll send out, is really an awesome article. There's a few things that I don't want to get into too many details, but it may be that we may not know, or we may not have, we may have a hard time accepting, or we may be in denial about the poor outcomes of resuscitation, especially for older adults. Again, this was a sub-analysis of patients who are 80 and older. We may attempt CPR out of respect for autonomy by just assuming that CPR is default because we haven't had these conversations with them. That's why proactive goals of care conversations are so important, because default CPR may not be what actually the patient wanted. analogy I really like about us being able to provide recommendations regarding life-sustaining treatments is considering this as like a roadmap, a destination. So if the patient's values are to be at home and to remain independent, that's really their destination. So how do we get them there? That's our directions that we would give to them. Those are the treatments we would recommend for or against. So if we don't know their values, how can we recommend the right directions? I mean, they'd be going all over the place. So really, it's our responsibility to understand their understanding and to understand their values and then recommend for or against treatments. So how do we do this when we elicit values? These are, pretty good open-ended questions, and you don't have to ask all of these. These are obviously just examples. So you might ask, what matters most to you in life? Or what do you enjoy? What does a good day look like for you? Or what's most important to your partner to live well? For example, if he was having a good day, what would happen on that day? These are opportunities to ask. You might say this again at the end of your H&P, for example, on inpatient, or you're on outpatient and you're having this conversation. You'd be surprised how much you get a chance to learn about what's most important. So specifically regarding health in the future, you could ask what's most important to you as you think about your health for the future, or what do you hope for with your medical care, or is there anything that would be helpful for me to know about your religious and spiritual beliefs? It's helpful too. And then you summarize. So you've heard, hey, XYZ, this is all really important to me. So you just restate it. Thank you for helping me better understand what matters most to you. This is what I've heard. And then you ask, you check in, does this capture our conversation accurately so far? And it really helps patients to feel heard. And then when you start the discussion about LSTs with a transition statement, you could ask, you can throw out a softball kind of question, a screening question that doesn't force the issue into immediate choice. So you could say something like, or question something like, as you think about your values in medical care, are there any medical treatments or procedures that aren't acceptable to you? Because we need to know things that both are acceptable and that are not acceptable. So this is a nice table from Respecting Choices that really conceptualizes these values. So for some, it might be living longer. What does that look like? And then the middle column, maintaining current health, and then the column on the right, comfort. I won't go into this, but I think it's a nice way to conceptualize this as well, just a different way. And so once we know the values, we can make a recommendation. So always ask permission to make a recommendation. I think that, again, is a nice transition. And we want to recommend a plan that aligns with their goals. Again, if we don't know their goals and values, we probably don't feel comfortable making recommendations. So we want to focus on what can be achieved, what might be possible, and what to avoid if it's not going to help meet the patient's goals. And then, again, checking in, does that seem right? When you have these conversations, especially in the time of COVID now, I think what's probably the most important LSTs right now are CPR, mechanical ventilation, whether or not patients, whether or not it's in line with their values to transfer to the hospital and into higher levels of care in ICU, for example. This is the table in Respecting Choices that is supposed to align with that previous table. So full treatment you would think of as full code, how it looks in EPIC. And then in the selective treatment column would be probably the equivalent to a DNR-CCA, for example, if you wanted to conceptualize this a little bit more. And then the comfort-focused treatment, of course, would be like a DNR-CC. Now at the VA, we don't have DNR-CCA. We have DNR and full code, but what we have instead are the other life-sustaining treatments. So every life-sustaining treatment that's withheld, for example, would be like mechanical ventilation if a patient does not want that or transfers to higher levels of care. Those are all separate orders that go in the chart. So now we're going to do a case with Dr. Brown as an example for how to have a proactive goals and care conversation. Now, like I said, so this is, these conversations may not feel natural at first, but the more you have them, the more you use the language, the more natural it feels. And even if it feels hokey at first, it definitely, I think, can feel more natural the more you do it. So we have an 80-year-old gentleman. He's got heart failure. He's dyspneic on exertion. He has COPD. He's got 2 liters of oxygen at night. He's had 3 hospitalized exacerbations this year, and he probably suffering from that too. He's got heart disease, low back pain, some NEOA. He's got kidney disease, some difficulty with his ADLs. He may or may not have dementia, but he's living at home with his family. And so we've already asked him what's most important, which we'll role play. But the things that are most important to him are spending time with his family, playing the banjo on the porch with his dog Chewy, listening to music, living at home, minimizing his time in the hospital, being independent, and managing his shortness of breath. So would it be reasonable to, talk about obviously CPR with this patient to give outcomes? It might be. Do we think that CPR will help our patient achieve his goals? What do you think? Do you think CPR is going to help him achieve his goals? Yeah, thanks, Annie. It's not going to. Oh, okay, Gordon, I appreciate the yes. Okay. All right. Yeah, it's okay. Okay. Yeah, it's not going to, but I appreciate your positivity. So would we recommend for or against CPR and invasive mechanical ventilation for our patient? Recommend for or against? Yes, against, yeah. Yeah, and that's our responsibility, right, to make a recommendation that's in line with their values. And then we would be able to give CPR outcomes really if there's an incongruency here. So for example, we're going to start with this is one way you can introduce the conversation. So at the Cincinnati VA, it's important for us to honor our veterans' choices. If we wait until a hospitalization or crisis to talk about important medical decisions, our veterans are often too sick to tell us what they would want. Instead of waiting until an emergency, I'd like to spend time talking with you about how the things that matter most to you, about what matters most to you, and about the kinds of medical treatments you would and wouldn't want in an emergency. It's really important for us to do now with COVID-19. Does that sound okay with you? So this is one way to introduce it in the outpatient setting. And a nice thing about doing this in the outpatient setting is you can actually just have a separate visit for that and bill for it as well. So that this is a natural kind of introductory question. On the inpatient side, you might see something like, I'd like to spend a few minutes talking about the things in life that matter most to you. Knowing what's most important to you can help our team make recommendations about your medical care. Can you share with me what matters most to you? Or what does a good day look like for you?
I love spending time with my family and playing banjo on the porch with my dog Chewy. I also love listening to music. Living at home and being independent are really important to me.
Those are great things. It sounds like being at home with your family is really important, and your dog Chewy is a special companion. You also love to play banjo and listen to music. Being independent is really important to you. Did I get that right?
You sure did.
As I mentioned before, I want to be sure that you get the care that focuses on what matters most to you. So to be prepared, it's helpful to know in advance whether you would or wouldn't want certain emergency treatments.
I like to be prepared.
As you think about your medical care, are there any medical treatments or procedures that aren't acceptable to you?
What kind of procedures?
Procedures like cardiopulmonary resuscitation, which is also called CPR.
Yeah, I think I would want CPR.
Okay. Would it be okay if I make a recommendation about CPR based on what you said is most important to you?
Sure, that's fine.
I know that being independent, being with family, and at home instead of in the hospital are all important to you.
That's right.
I'm concerned that CPR won't help you live the life you want. If you survive after CPR, I'm worried you won't be able to go back to going back home and play banjo on the porch with your family, and to be with your dog Chewy or listen to music like you love.
I really want to be able to do those things. Think I wouldn't be able to?
Fortunately, I think you wouldn't. I worry your brain could be damaged if it doesn't receive enough oxygen, which would make it hard for you to recognize and interact with your family and take care of yourself independently. Your COPD has been advancing for some time now, and I worry you would be able to come off of a breathing machine where a tube would go down your throat and into your lungs. I worry you'd always need it to breathe for you.
I don't want that, actually.
So for these reasons, I recommend that when your heart and breathing stop, we allow for a natural death instead of attempting CPR or putting you on a breathing machine.
I don't want to end up stuck on machines. I want to be at home with my family and Chewy. That's what I want.
Okay. So, there we can, probably move forward with recommendations at that point, saying, sounds like, what's most important to you are what you stated, and, we would advise for a natural death, for example. So how do we explore inconsistencies and limits? So if there's an incongruent or a discord. So if somebody says, no, I still want CPR, you would ask something like, well, can you share with me what you're hoping for with CPR? Or is there a situation you could imagine when you wouldn't want CPR? So it might sound something like this. For these reasons, I recommend that when your heart and breathing stop, we allow for natural death instead of attempting CPR putting on a breathing machine.
I think I still want that.
Can you share with me what you're hoping for with CPR?
When it comes right down to it, if there's any chance I'd get another day with my family and Chewy, it'd be worth it, even if I end up in a nursing home on machines. I know CPR might not work, and I might be in a terrible shape and stuck on machines, but I want to give it one try.
I understand, and I can see how important your family and Chewy are to you, and I really respect that. Can you think of a situation when you wouldn't want CPR?
I want to give CPR a chance, but if you try it and afterwards I end up as a vegetable, then I don't want it again.
Tell me what you mean when you say end up as a vegetable.
If I won't ever be able to take care of myself or make my own decisions, or if it's going to be really hard on my family, then I wouldn't want CPR.
And it sounds to me like you understand there's a very great chance you won't be able to take care of yourself or make your own decisions, even if you survive after CPR is tried the first time.
That's true. I understand the risk, but at this point, it's worth it to me to try once.
Okay, so to make sure I understand your wishes so I can honor them at this point, you want an attempt at CPR when your heart and breathing stop. If you're ever permanently unable to take care of yourself or make your own decisions, then you wouldn't want CPR. Does that sound right?
Yeah, that's right.
And briefly, if at this point you could say something like, really clarify that the surrogates need to be involved to understand this, so that if they were ever faced with having to compassionately extubate or stop interventions, if the patient were sick in that situation, that they are prepared and understand what that means. And so incorporating surrogate decision makers in the dialogue is really important. So you could say something like, we should let your daughter Sophia and nephew Jim know, since they're the people you chose to be your healthcare agents. They'd be the ones who let the medical team know your wishes if you can't speak for yourself.
That would be good. They might have some questions.
I'll also document your decisions in the medical record. Thanks for spending time talking about this. I know these conversations can be hard, and it's really helpful for us to know what you want. I look forward to meeting with you, Sophia and Jim.
Thanks, Doc. This is hard stuff to talk about, but I'm glad we did. I'll see you soon.
And when you have these conversations, it's helpful to, if you can have the surrogates on the first phone call, that's great. If not, then subsequent phone calls is great too. When we talk about when patients say, well, I still want to give it a shot, or I want to try it, and if I'm a vegetable, then you should just stop everything. Some patients might also say, I want a certain time-limited trial, like a certain amount of time regarding mechanical ventilation or other life-sustaining treatments. So this would be an opportunity to really clarify that time frame and document that. So Dan, you had asked, how would you document such a discussion in an LST note? So when you do the LST, and there are 8 questions in LST, most of which are really quickly just kind of identifying phone numbers and names, and the real meat is the code status and other LSTs like mechanical ventilation. For the things like, well, a time-limited trial, or if a patient is unable to be extubated and have treatments removed and maintain, a meaningful neurological recovery to them, you would document all of that so that you could just literally say, this is what the patient means by when they say quote unquote vegetable, or this is the time-limited trial. So a full advanced directive. So advanced directives are different than the life-saving treatment notes. So the advanced directives really just name who the durable healthcare power of attorney is. A living will does, like you were mentioning, does put information about potentially poor neurological recovery, if somebody is not going to have a meaningful recovery when the patient would want to be taken off those interventions. So that's in the living will, but what the LST provides is to know, like, does a patient, does their values really align with even initiating those treatments, starting mechanical ventilation, transfers to the ICU, CPR, things like that. So the living will is just really addresses kind of after those interventions are already initiated. And you can put that all in the LST, absolutely. There's a lot of free texting. In fact, after you've gone through the asterisk questions in CPRS, you can free text it in the notes and make any changes you want. And then you can always addend the note too in CPRS. So we're at the end of our presentation. I just wanted to have you just jot down 3 takeaways for yourselves, and think about what those might be. And if you want to share some of those now in the chat box, by all means do so. Yeah, totally. I wish I were statements like game changing. Yes, that's awesome, Natalie. Yeah, it's a great quote. No matter what you decide, you'll be treated with dignity and respect. Yeah, so suggestions for supportively curbing unrealistic expectations. This kind of goes back to the our agenda and their agenda kind of maybe discord. So what's really helpful is to understand any kind of trepidation about avoiding certain treatments and what that means. So what are we really asking about? It's probably fear, like the fear behind death, or the fear about the process of dying, the dying process. These are all extremely emotionally charged. We all have a lot of fear about what that looks like. So the more you can ask patients and their families to really describe what worries, tell me what worries most to you. What's your biggest worry about, doing XYZ or not doing XYZ? And then asking for permission before we give data. So always, asking would it be okay if I shared some information, because I worry that some of those treatments may not actually be in line with what dad's values are, or I worry some of these treatments may not be beneficial like we all are hoping, things like that. Dr. Coverly, like what you said, the phrase natural death, yeah, I think it's a very beneficent way to put it when we're talking about beneficence versus non-maleficence. Again, going back to that one article is, oh, thanks, Dr. Coverly. Going back to that one article, that sub-analysis of the resuscitation appropriateness, I think knowing that ethically, it's really important that we recommend for or against treatments that we think are in line with what's humane for patients. So, for many patients who have really significant multimorbidity and frailty, and we really do worry that they would not survive CPR or at least have a meaningful neurologic recovery, then really ethically, it is important for us to be able to communicate that in a way that's sensitive and obviously curious about the patient's fears. But unfortunately, even if there's some incongruence or discord, we may not be able to change the trajectory of how somebody perceives their current healthcare status until they're ready. Anybody have any other questions? So some takeaways that I just wanted to put down would be, asking for permission to have the conversation and throughout those transitions. It's really helpful for us, honestly, and it gives patients kind of like a warning shot about okay, we're moving throughout the conversation, recognizing emotion, overt or hidden, and naming it, which is super useful and really dissipates that tension. The I wish and I worry statements are powerful, like you all had mentioned. Understanding patients' values, again, we can't really make recommendations until we really truly understand what's important to them. And then restating or summarizing so that we can make the recommendations and align the plan. So the LST note is universal across all VAs. It's a national initiative. It's actually called formally the Life Sustaining Treatment Decision Initiative, and it started 3 years ago. So now you all are very like emotional warriors. You have high EQs, and we'll send all the information that I referenced. Like I said, the more you use it, the more natural it's going to feel, and it works. Not only really well with patients, but in your personal life. These are great ways to communicate with people that you care about too. So. Nobody else has any questions? Oh, thanks, Gordon. If nobody has any questions, we'll send the information out, and then please feel free to email me. It's Elise, ELISE.Henning, HENING2 @va.gov, which we'll send